So let's talk about anemia. Remember the blood components that we talked about before? Plasma makes up a lot, formed elements make up less, and in total, the blood volume of the weight of the blood volume is about 7% of the body weight. Blood cells form about 45% of that volume, and remember the blood cells consist mostly of red blood cells. Less than 1% are platelets, and less than 1% are white blood cells. So the RBCs are the most abundant cells in the body. 80% of the cells are red blood cells. They are small biconcave discs. Remember, they live for about 120 days. Why is that important for us to know? Well, because, you want to know how the body works, but also because when it comes time to look at somebody's blood sugar control over the last 3 months, the reason that the number is 3 months is because of this, because we want to know those red blood cells, how much exposure do they have to glucose, right, in the blood? And we have to keep in mind that happens over a period of 3 months or 4 months. So the minimum amount required for testing the average daily blood sugar through that test, the hemoglobin A1C, is 3 months. So the hemoglobin molecule, remember, has alpha subunits and beta subunits. That's unimportant. The fact is that they can hold 4 oxygen molecules. Each of these hemoglobin molecules can hold on to 4 oxygens. Now, some patients develop anemia. And when they develop anemia, we need to be able to figure out what kind it is. Is it anemia because of, lack of red blood cells? Is it anemia because of lack of iron? Is it anemia because they have some genetic abnormality? Well, we can use the red blood cell indices on the CBC to figure that out. And the two that we use primarily are the MCV, the mean corpuscular volume, and the MCHC, which is the mean corpuscular hemoglobin concentration. The MCV tells us about the size, right? The mean corpuscular volume. What is the volume of red blood cells that are in a given sample? And this is how it's calculated. It's the hematocrit divided by the RBCs per microliter times 10. And so that tells us about whether the anemia is microcytic or macrocytic. If the MCV is high, then it's macrocytic. If it's low, then it's microcytic, right? Easy. The color then comes from understanding the MCHC. That is the concentration of hemoglobin in the average red blood cell. And here's the formula for that. So when we're talking about the color of the red blood cells, the MCHC tells us whether this is a hypochromic, if the MCHC is low, or hyperchromic, if the MCHC is high, kind of anemia. So the CBC gives us a lot of information, and we have to pick it apart to find out the information that we need for evaluating anemias. So we always start with the hemoglobin, right? Well, if you're a medicine person, it's hemoglobin. If you're a surgical person or peds, it's hematocrit, but we're going to use hemoglobin because that's what I know. We're going to start with that and know that we have an anemia present because the hemoglobin level is low. Next, we're going to look at the MCV and the MCHC to tell us the size of the red blood cells and the hemoglobin concentration, or the color of the red blood cells. We can also do iron studies. We can measure the direct amount of iron in the blood, and then we can measure the total iron binding capacity, or TIBC, and we can measure the ferritin, levels as well as transferrin and some other things. But these are the major ones that we look at. So let's think about what are the reasons that you can have anemia. Well, you can have blood loss, right? You can have chronic blood loss anemia, where somebody, for instance, has a colon cancer, and that colon cancer leaks a tiny bit of blood, but it happens every day for a year. Well, you're eventually, because your body can't suck up all that iron from the diet, it needs to use red blood cells, but those red blood cells are being lost, so it can't keep up, and therefore you get anemic, right? That's the scenario. And so we can see chronic GI bleeding producing anemia, and that's one of our diagnostic tests for colon cancer. Now, there's other ways that we can lose blood too, right? You can have an acute GI bleed. You can have trauma. You can have blood loss during surgery. Women have blood loss during menstruation. There's lots of different reasons for blood loss. So once we find that somebody has blood loss anemia, right, or anemia, then we have to look and see what kind of blood loss anemia they have, perhaps. Now, you can also have faulty RBC production. So that happens if you don't have all the right building blocks. Well, what are the building blocks? One of them is iron, right? So as we alluded to, if you have a colon cancer and it's leaking a little bit of blood in your stool every day, not enough to see with the naked eye, but every single day you're losing more and more red blood cells that can't be recycled into the components that are needed, principally iron, to make new red blood cells, then you develop this iron deficient anemia. Okay? You can have bone marrow or stem cell problems. We have this problem with aplastic anemia, lead poisoning, thalassemia, different other reasons for stem cell problems. We can have vitamin deficiency anemia, like B12 deficiency or folate deficiency. We can have sickle cell anemia. We can have anemia of chronic disease, where there's just this chronic disease that's present that prevents a correct amount of erythropoietin production, etc. And then there's something called hemolytic anemias. And so these can be immunologic, right? One of the recurring themes in pathophysiology that we talked about the first week. If your body is attacking your own red blood cells, then that's a problem. It may be that there are toxins that you're exposed to, whether it's occupational exposure or something else, can be genetic causes. And of course, anything that's in the blood that's metal can certainly produce hemolytic anemias. So in the old days, when we were making or learning to make cardiac valves, we had the ball and cage valves. They chewed up a lot of platelets and a lot of red blood cells. So some of those cardiac devices, also balloon pumps can do it in the ICU. The older versions of the assist devices and things like that. So lots of cardiac devices can chew up all of the red blood cells and produce that hemolytic anemia. So the most common of these is really iron deficient anemia, at least in the general sense of the general population. And that is recognized because it's microcytic and hypochromic anemia. So they're small and pale red blood cells. The transferrin is increased because the body's trying to keep up, right? It's taking all of the iron that it can and sending it to the bone marrow. That means the transferrin levels are going to be high. Even though there's iron deficiency, it's trying its best to move all the iron that it can, and that's why the transferrin levels can be high. The transferrin saturation, though, is low. It doesn't have enough iron attached to it, and so that value is low. So is the ferritin level, because remember, ferritin is the storage form of iron that gets stored in the liver and in the muscle cells. anemia of chronic disease is really a diagnosis of exclusion. It may be associated with iron deficiency as well, but renally induced anemia and other anemias of chronic disease, we make that diagnosis after we figure out that it's not any of these other forms. Hemolytic anemia has a very characteristic look under the microscope. We have these irregularly shaped, jagged cells that can happen, and these are called schistocytes, and these are the schistocytes. And then these are helmet cells, I think. Those are also characteristic